I would like to welcome everybody for attending the Behavioral Health Administration Provider Convening for the month of March. My name is Joy Hart. I'm the Division Director for Statewide Programs, Technical Assistance, and Innovation. And it is important because providers are essential to achieving the BHA's vision of a comprehensive, equitable, accessible, and effective continuum of behavioral health services for whole person health. And I would like to go ahead and next slide and have Webster Hendricks come on.
Thank you, Joy. Before we get started today, I would like to remind us all of the BHA mission, and that is to co-create a people-first behavioral health system that meets all of the needs of the people of Colorado. Next slide. In an effort to meet that, accomplish that mission, we also have a number of values that we would like to make sure that we all keep in mind. One of which is collaboration, and that is working in partnership to realize a holistic behavioral health system. The vision, community-informed practice, is integrating evidence-based guidance with lived expertise to make sure that the system is working as it should. Equity, excuse me, naming the root causes. I apologize. Naming the root causes of injustices and allotting the necessary resources to support the desired outcome and getting those changes happening. Generational impact, engaging in meaningful and thoughtful action to create a new legacy in the behavioral health world system in Colorado, and truth, being transparent and accurate with addressing the people of Colorado, making sure that everyone is aware of what we're doing and how we're getting it done. Thank you, Joy.
Okay, let's go ahead into the next screen. I want to acknowledge and welcome Maureen Macheco as our Deputy Commissioner of Equity and System Effectiveness. And then also, not on this screen, but Megan Shelton is currently serving as the interim Strategy Planning and Engagement Division Director, and you'll be hearing more from her next week during our town hall. Next slide. And I'd like to pass it over to Statewide Program Directors.
Perfect. Hi, everyone. I'm Wendy Simmerman. I'm the Director of Workforce Development, and I'll send it to Danielle.
Hi, good morning, everyone. Actually, good afternoon, actually. I'm Danielle Culp, and I'm acting as the Interim Director of Criminal Justice Services. I'll pass it over to Paul.
Thanks, Danielle. Hi, everybody. My name is Paul Barnett. I'm the Director of Child, Youth, and Family Behavioral Health. My pronouns are he, him. And I will pass it to Mark.
Thanks, Paul. Hi, everyone. Mark Conagini, Director of Adult Treatment and Recovery here in the Statewide Programs Division of the BHA. I use he, him pronouns. And I want to make sure we acknowledge we've developed our internal team here to help support offering these provider convenings. Melissa, Sharon, Desiree, Marina, Mary, Megan, and Webster. Feel free to say hello.
Good morning, everyone. Good afternoon, I think.
Afternoon.
Great. All right, we can go to the next slide, please.
Actually, if I could just go over some housekeeping items.
Yes, absolutely.
Okay, so for rules of engagement today, we're expecting a large audience. Therefore, everyone has been muted to reduce background noise. Make sure you're muted when you are not speaking. If you have a question throughout the presentation, you are welcome to use the chat or use Zoom's raise hand feature. Questions will be addressed by the chat moderator when it's appropriate. If you have an opportunity to speak, we kindly ask that you introduce yourself and your agency. We do have Adrian and Kimberly as our ASL interpreters today. During the event, you can spotlight your ASL interpreter so they will appear larger on your screen. You will have the ability to change your view at any time. In the upper right-hand corner of your screen is a view button. Use this to toggle between speaker view and gallery view. You can also hover over the right corner of the ASL interpreter video and select pin if you would like to see them larger on your screen. Thank you.
Thank you, Des. Wendy, you're up.
Thanks, Mark. Okay, I am excited to share with you two things that are coming up in the peer support space. If you'll recall, back at the end of January, we put forward a peer funding allocation plan, which dealt with SB 22-181 and funds that had been allocated to build out, strengthen, and support the peer support workforce. As part of that plan, we established a peer support steering committee, or we will be establishing, and we'll have applications open throughout the month of April with the intent of beginning our meetings in June of 2023. Next slide. The second initiative that you should know about right now is that we are going to implement quarterly peer support workforce collaborative meetings. These will be held online so that they can be accessible to everyone throughout the state. Our first meeting is April 12th at 12 o'clock at noon. If you would like to make sure that you're on the list to receive notifications about either of these initiatives, please feel free to share your email in the chat. If you're not comfortable sharing it with the entire group, you can also chat privately with Lisa Madrigal, who will be collecting the email addresses for distribution. And we will get word out by the end of March with the application information. Thank you. I think it goes over to Aaliyah now.
Hi, everybody. So I'm going to discuss, we are going to discuss, a couple of us, recovery residences here in Colorado. On May 23rd, 2019, House Bill 19-1009 was signed into law. This bill was directed to have the Behavioral Health Administration, it was OBH back then, to select a certifying body for recovery residences, sober living facilities, and also sober homes. This certifying body was to incorporate National Standards Certification Process, which is NAR, the National Association for Recovery Residences. All recovery residences will be required to be certified by a certifying body in order to operate in Colorado. Chartered Oxford houses are specifically mentioned in this statute as not needing to be certified. Oxford houses are democratically run with no staff on site. Colorado Agency for Recovery Residences was selected to be the certifying body through this competitive process. Next slide. Thank you. Effective July 21st, 2021, Senate Bill 21-137 called for a competitive selection process again, and to select another recovery residence certifying body. CAR was selected for this one as well, and it was to certify recovery residences like it was before, and also to educate and train recovery residences on industry best practices, including cultural responsiveness and trauma-informed care. I am going to put CAR's, Oxford houses, and NAR's into the chat. I'm going to put their websites into the chat so you can check those out. Next slide, please. I'm on two screens. Senate Bill 21-137 also had assistance in housing assistance in the bill as well. So $4 million was added into this bill. And this was for transitioning out of residential treatment or receiving treatment for substance use conditions. The BHA allocates these funds to MSOs that support people who need financial support and want to stay in either a CAR certified recovery residence or a chartered Oxford house. The use of funds are a max of $4,000 a month, and the vast majority costs less than $1,000. So I am going to go ahead and introduce Butch from the Colorado Agency for Recovery Residences. He is the executive director. And when he's done talking, we're just gonna put it right back over to Taylor. And he's from Oxford House, and he's the lead coordinator, senior coordinator. If you could say what your Taylor, when it gets to you, what your real title is, that would be awesome. So next slide, please. Oh, it's on there. It's on the thing. Butch, you're up. Next slide.
Thank you, Leah, Dr. Medlock, and BHA for allowing CAR and Recovery Residences Journal to be able to come and speak with you guys today. We're really excited for this opportunity to just be able to educate a little bit more about what recovery residences do here in the state of Colorado, specifically in regards to CAR. I'm going to stay away a little bit from how we operate because we operate very similarly to what Taylor is going to cover. As far as how the houses operate. And so he's going to go a little bit more in detail on that, but there are some distinct differences, but Taylor will also go into that a little bit more. Can I get the next slide, please? So the four main areas that I want to hit on today is going to be the state report, certifications, grievances, and how we work with state, county, and city governments. Can I get the next slide, please? So, and then the next slide. So what I'm going to do is start off with this book right here. This last year, CAR published a training guide for all the recovery residences in the state of Colorado. This guide included multiple sections on what we would consider best practices. CAR main focus is to support, train, and to certify our recovery residences here in Colorado. We really want to focus more on that support and training aspect of educating our providers and the organizations that operate these recovery residences. So this last year, we published this book, and it hit on some of the more difficult areas that our recovery residences were facing. And a lot of these chapters, we brought in and consulted the BHA on, such as the LGBT and inclusiveness in recovery residences, medication-assisted treatment, and how to deal with MAT in recovery residences. One of the laws that we didn't touch on is that all recovery residents in the state of Colorado that are receiving any type of form of state funding must support medically assisted treatment. Now, they can become certified while not supporting MAT, and we have a lot of religious-based programs in the state that operate that way. But if they are receiving any form of state funding, state statute does say they need to be they need to support MAT, and so we put out a best practice that addresses that. But then we also tried to help and train our recovery residents on in things like parents with children and how to address relapses in the house, and then supporting individuals that are returning from incarceration. Next slide. So one of the areas, the biggest area in this book that we published goes into the standard. CAR has about 252 standards that we look at when we're certifying a recovery residence. Each one of these is designed to ensure that a program covers different areas, but also supports that recovery has different pathways. And what we want to do is make sure that all the programs are being able to operate independently. They support multiple pathways of recovery, but they cover certain areas like what are we going to do in case of a discharge? How are we going to handle relapses? How are house meetings? What are your policy and procedures that the residents in the house are expected to operate? And so the four main areas that we look at in the certification process are your administrative policies, like your bookkeeping and things like documents that are attesting to compliance with other state and federal laws, that all the residents are getting equal opportunity if by chance you have work. And so we're going to look at some of those administrative, and then we're going to go into the physical environment of the house. We've gotten together with many of the municipalities throughout Colorado, and what we do is we expect to the 2015 International Residential Code, or IRC. And so we partnered with the city of Aurora and their systematic housing inspectors and came up with these standards that we look at that are mainly around life and safety of the individuals. Are there egress windows to the houses? Especially in basements, I would say that's a big one. Are smoke detectors and carbon monoxide detectors properly placed throughout the house? And here again, when we go in and we're expecting for this thing, we work with the recovery residences to ensure that all these safety measures are in place for the house and that they're operating safely. We had a situation half a decade ago where recovery residences were picking up the cheapest houses possible, and a lot of these homes didn't have egress windows. And so with the help of the BHA, CAR, and MSOs, we've gone in and be able to support these recovery residences just to make sure that these recovery residences are safe. Outside that physical domain, we're also going to look at the recovery environment of the house. Is the house supporting your recovery? Every time we go in to do a certification or recertification, one of the first questions that we ask is, do you feel supported in your recovery in this home? And if not, we receive a no response to that, then we dig a little bit deeper and we work with that recovery residence operator to be able to train them to make sure that all the residents are feeling supported in that recovery environment. And then the last area that we're going to look for is good neighbor policies. We want to make sure that recovery residences are taking into consideration things like smoking. If in some of these houses, we can have 8 grown men or women that are in these houses. And so what we want to do is make sure that there's like a designated smoking area so we don't become a blight on the community and impacting the community in a negative way, but that we're seen more as a positive environment in the community. And I would say that when we first go into a community, or when a recovery residence program first goes into a community, there's some strong concerns from the neighbors. But what we have seen is over time that the recovery residence is typically seen as an asset to the community, because a lot of times they will go in and shovel snow to their neighbors' driveways, help rake leaves. And in a lot of instances, when we have elderly individuals in a community, they'll help them move furniture with deliveries. And so they're seen more as an asset as time goes on in the community. And so those are the 4 main areas that we're going to inspect for. There's about 252 different standards that a recovery residence goes through when going through the certification policy. Just touching back on that administrative piece, one of the other big pieces that we look for is their policy and procedures of the house, and that all of these different standards are included in those policy and procedures that are outside of that physical environment. Next slide, please. Okay, and so one of the other things that we do is grievances. Now, how CAR handles grievances is we have tried our best to mirror the BHA in how they handled grievances, and have tried to adopt policies that mirror the BHA as close as possible. And when we run into a difficult grievance situation that's been filed, a lot of times I will refer or call Tom Miller, who's been an invaluable resource to us over at the licensure department, and ask, okay, here's our situation. Is how we are looking at handling this appropriate? How would you guys handle it differently? And over the course of several years now, we've kind of learned from them on how they handle grievances, and have tried to just mirror that as close as possible. One of the things that there's not a slide in that we're in the process of adopting right now is critical incident reporting. And as the BHA is redefining how they're handling that, we will adopt that as soon as that gets finalized with the BHA also. Next slide. And then one of the big things that we also do is we work with a lot of the state, county, and city governments. I know when I used to be a recovery residence operator years ago. And when I first got into this, there were a lot of municipalities that were uneducated on what a recovery residence was, how the Fair Housing Act and the American Disability Act applied to recovery residences. And so over the course of the last year or two, we have really gone in and worked with city administrators, city managers, and city attorneys and educated them on these situations, kind of how recovery residences work, how they're protected by the FHA. And I would say in most part, we've been able to avoid litigation in the state of Colorado. I don't know of any case that's gone to litigation in the last couple of years around recovery residences and how they work and interact in a municipality. And so it's been a lot of training and a lot of hard work by everybody, but that's another one of the things that we have worked really hard on. And I would say we get phone calls probably weekly from either a police department or a municipality on how do we address this issue? What do you think about this? How does this incorporate into the CAR standards? And through a collaborative effort, I think we've really kind of recreated how recovery residences or sober living homes are looked at in the state of Colorado. Next slide, please. And then finally, we do a lot of state reports. And so a lot of collection of data. We are in the process of trying to get a little bit better at this in incorporation of software that will allow us to get a little bit deeper into the recovery residences. And so that's something that we're working on right now. But as an example, if we can go to the next slide, right now, some of the things that we look at and are tracking is how many certified homes. There's 238 certified homes in the Colorado representing 2,396 beds, or 1,729 male, 667 female beds here in the state of Colorado. And that number is growing every year. I would say in the last couple of years, we've grown for about 25%. And this next fiscal year, we are really trying to focus on our rural area expansion and supporting our recovery, the recovery courts or the drug courts in these municipalities that don't have any recovery programs in their districts or their counties. And so we're really trying to focus on expansion to rural area services and just data collection in general. I think the last slide is the thank you slide. And so I think we have time here at the end, but I'm going to pass it over to Taylor. But my contact information is here. If you would like to reach out to us, we would love to answer questions and support you any way we can. Taylor?
Thank you, Butch. We can go ahead and go to the next slide, please. So, hello, everybody. My name is Taylor Wright. I'm the Senior Outreach Coordinator for Oxford House Incorporated in Colorado, which basically means that I'm the outreach supervisor. We have 9 different outreach in different regions of Colorado. And their sole responsibility is to open new Oxford houses, community outreach, and then provide training and education for the houses and the chapters, which I'll get into here in just a minute. Next slide, please. So Oxford houses operate with 3 core principles that secure their charter requirements. The first one being that they're democratically ran, meaning that each member, regardless of whether they've been there a year or a day, has a vote in the individuals that come and go, what bills they may pay in one house. Basically, any decision that affects the entire house, each member has a vote on, and the majority rule is the deciding factor on that vote. The financially self-supporting piece of this is that each house has individuals, typically somewhere between 7 and 10 individuals that live in each house, and they pay what we call equal expense shared, which generally is somewhere between $650 and $750 per month that goes into the bank account for the house and that they use to pay their bills. And that includes the rent to the landlord itself, their utilities, and so on and so forth. Even so far as to open up a savings account and keep a surplus for when times may be hard in terms of filling the house or inflation or things of that nature. And then finally, immediate expulsion for relapse. This is not to imply that individuals who relapse are not allowed to be accepted back into an Oxford house. It's just to say that in the immediate circumstances of a relapse, that individual is asked to leave, and then they can prove to the house that they may re-interview with, or to another house, that they've got their recovery plan in place. Our houses are all gender specific. Most of them, there is a minimum to be chartered as an Oxford house of 6 beds. I'd say for the most part, so that we open up the most opportunity in Colorado. Generally, like I said, they're somewhere between 6, 7, and like I said, up to even, we have one house in Colorado that has 12 beds. So we shoot for as high as we can to open up more opportunity for more individuals. And then, of course, adherence to the Oxford House model, traditions, and the manual, which I'll go into in just a minute. Next slide, please. So our origin, this just kind of covers some of the details of where we started and where we are now. The first Oxford House was opened in Silver Spring, Maryland by our recently deceased CEO in 1975. Since then, and this number is actually somewhat accurate, but we've also grown by 200 homes in the course of when this slideshow was created a couple months ago. So we're sitting at just north of 3,500 homes nationwide, which would increase the number of beds. We are still in 47 states and 5 countries. The foundation that we started is that nobody is ever asked to leave without a cause. So if an individual displays certain behaviors that don't align with recovery, they're participating in things that they shouldn't be, which is determined by the house based on the behaviors that they're seeing, that they aren't really involved in their recovery to begin with, that they're lashing out at their roommates, things like that. Of course, a relapse is also one of those factors, but they're never asked to leave, and they are provided an opportunity to share where they're at so that the most educated decision and the best interest of the house can be arrived at. Houses are available to men, women, and children, women themselves, and then men and children. We do have around 14 or 15 homes that provide opportunity for children to be included in the Oxford House environment. Our houses in general, this is a snapshot of one of our recently owned houses in Longmont, Colorado. Generally, what we look for in Oxford houses are larger homes. I'm talking about a minimum of 3-bedroom homes with generally an open area in the basement for us to add on to additional bedrooms. And some of the things that Butch had mentioned, having egress windows in areas that are typically non-conforming are very important, so that above all, we have a safe place for the individuals that are residents of our houses to live. We do look at long-term leases in nice neighborhoods to create a long-term relationship with these landlords so that this opportunity is open for as long as possible. We do look at things like adequate parking so that you have 8, 9 individuals in one house and they all have vehicles. We have to abide by what the HOA might dictate in certain neighborhoods, although we try to avoid that. But before anything else, we want to make sure that our neighbors don't see us coming into that neighborhood and they raise all these question marks, and then they can become disgruntled because we're taking up, parking space, and it starts to look like a cluttered environment. Most of our members don't have their own mode of transportation. So we do look at public transportation, bus routes. We don't like to open houses anywhere outside of around a mile proximity from the house to the bus stop itself, so that they have access to the resources that they need, close to employment opportunities as well. And first and foremost, close to 12-step meetings, IOP type settings, treatment providers, individual care, peer support groups, things like that they clearly need to support and enhance their recovery. Next slide, please. Our membership qualifications, one of the following is required: completion of an inpatient treatment facility, completion of medical detoxification. This basically states that we are open to all pathways of recovery, regardless of what your background look like. These are just typical qualifications of what our applicants have recently come from treatment, from withdrawal management, from the street, from a homeless coalition, something of that nature. But we don't turn our back on any individual that is looking to apply with an Oxford House. And at the bottom, I would say is the most important portion of this, because this is required of all members and requirements for the Oxford House charter status, is for them to be willing to work a recovery program. That is at the top of our list in terms of the applicants that apply for Oxford Houses. Do you have a plan for recovery? What are you willing to do for your recovery? Who is involved with you in your recovery, whether it be a person or an organization? Then their ability and also willingness to do everything that they can to share their equal, to get to the point where they can pay their EES themselves and improve that situation. Is that 2 minutes left altogether?
Yes.
Okay. And then adherence of the Oxford House model and house guidelines. The vacancy website, this is by far the most important resource that we have made available to the public. Individuals can log onto this website and directly apply and have contact information directly to Oxford Houses to set up an appointment to interview with that house. Next slide, please. Becoming a member, the best way to do this is to fill out an application, like I said, on the Oxford Vacancies website. Call the house directly with the interview with that number that's listed. Obviously show up for the interview on time. And then typically within 24 hours, they will get a yes or no based on the majority decision, and then be allowed to move in as soon as possible. Next slide, please. Membership. These are just some typical instances of individuals based on their background that they would seek our resource and apply to live in an Oxford House. It just comes from all different backgrounds in terms of our membership. Next slide, please. Our structure is based on 47 years of experience with the aforementioned 3 core charter requirements. We also, and these are all quality assurance measures. We have 9 traditions that we follow: house, chapter, state association manager, state association support rather, alumni outreach support, many different levels of quality assurance to make sure that each Oxford Houses are abiding by their charter requirements and are the most suitable environments for the individuals that are residents. Next slide, please. I'm gonna cut a little bit short, but I believe this slideshow will be made available, and I'm more than happy to answer any questions to follow.
There was one question in the chat from Elizabeth. Is children who are the client or with the parent, who is the client?
The parent would be.
Okay, thank you.
Mm-hmm.
All right, I think we are wrapping it up. I really want to thank so much Butch and Taylor for coming and sharing your expertise about how recovery housing in Colorado is regulated, how it's available, and the fact that there is some funding to support people. We know a good, safe, supportive environment is just instrumental to supporting people in those early stages of recovery. With that, and thanks for scrolling through the slides. We got some data. We will make these available. I do want to hand it over to Gina, Robin, and Boyd from Health Management Associates to talk to everyone about universal contracting provisions.
Thanks, Mark, and thanks everyone for allowing us to take a little bit of what's a busy agenda. We at Health Management Associates is here to talk to you about the universal contract provisions. We're working with BHA and HCPF on developing these for the state. So I am Gina Lasky. I'm in Colorado. I'm the managing director of behavioral health for Health Management Associates, and joined by Boyd Brown, who is in Minnesota.
And the two of us are going to spend some time with you. I think Robin actually dropped off. We hope to give you a little bit of a understanding of what the universal contract provisions are, the process by which we're trying to get feedback. And then if we have time, maybe ask you a couple of questions. What we really want to do is engage providers and other stakeholders in the conversation to get input and feedback as the universal contract provisions are designed. And so I'll put some information in the chat as we go about other opportunities to do that, because we know today is limited with many, many topics that are all worth lots of time. So if we can go forward, I want to give everyone a little bit of a foundation of why we're talking about universal contract provisions, what that is, and then again, also how to be engaged in the conversation. So as the BHA was being developed, if we go back in time a little bit to when the task force, the behavioral health task force was convened by Governor Polis, and there was a lot of work going on talking about what was challenging in behavioral health, what needed to be resolved. Part of the conversation that came up was duplication of processes, challenges with providers having to address multiple contracts with multiple state agencies, many, many different state agencies funding different provider programs and services, and then also intermediaries, the regional accountable entities, the managed service organizations, the administrative service organizations, all of those entities also contracting for services. So when the behavioral health administration model was created, one of the key distinction points, and I'm telling you this history for a reason, was to really think about whether or not all those programs moved into one place or whether programs stayed where they were. And part of the question mark at that time was, if you moved all the programs, you would get some reduction in administrative burden or changes in contracting. When the state decided not to move in that direction and have a model like the behavioral health administration that is networked, so programs stayed in multiple state agencies, the question became, how are we going to reduce some of that burden and create some streamlined structure for contracting as one piece of the puzzle? And so the way in which that was solved for was creating universal contract provisions. So I will explain in some detail what that means. But these were actually part of the model, and then they were part of the bill that authorized the behavioral health administration. And the contracting provisions need to be created by July 1, 2023 to meet a legislative deadline. The BHA and HCPF have asked health management associates to help understand the contracting processes as they exist and to support stakeholder engagement as well as some technical research to help create the universal contract provisions. And we'll talk a lot about what the goals of the contract provisions are and how those are going to look, but we'll just walk through a couple slides. I'm hoping we can do those fairly fast so that we can then ask you some questions. So what we are doing is working through two phases of stakeholder engagement. So the first phase, which is happening now, is to talk with state agencies, providers, intermediaries, and other stakeholders around, what do you think about universal contracts? What are the challenges in universal contract in contract provisions right now? What are some of the things you're hoping to get out of the universal contract provisions? And then we will come back in a second phase later this spring with draft provisions to get people's feedback. And we'll do the same thing. We'll go to state agencies, we'll go to providers, we'll go to intermediaries, we'll have broad stakeholder engagement. We really want to make sure that we've engaged people in this conversation. We are also doing some technical assistance to try to look at what is best practice in contracting in behavioral health. Are there other states who've created streamlined sets of contracts, and can we leverage lessons learned from those experiences around the country? We are also looking at contracts at all levels and crosswalking elements of them to see what's already the same and where are the differences, and then also trying to help the agencies with drafting these provisions. So lots of things happening in a short period of time. I'm going to put in the chat, if you are interested in joining future sessions on the universal contract provisions, there's a whole set of them on the website for the BHA. That includes some in-person and virtual options. So we are doing a couple of in-person sessions around the state, weather permitting, and then we are doing virtual sessions with individuals, and the ones in person are hybrid. So if you are too far away from the location, feel free to join virtually. And then we will have open forums. All of that is on the website. So would welcome people to join those sessions. And if we can go forward a slide. So this gets at why we are doing universal contract provisions. And so if you go back to what I said a couple minutes ago about, trying to solve for some of the challenges in the state, one of the things that was brought up in the task force was this complexity. And this is only some of the state agencies that were included in that complexity initially. And really the arrows you could think of as programs and contracts. So there are many state agencies in the state that have behavioral health programs. There are many state agencies that also then contract with behavioral health providers for those programs. There are other state agencies not on this slide that have behavioral health programs. They are not included in the universal contract provisions because they don't contract with providers. They do other things with their program dollars. But at least for these agencies, they are contracting with providers to deliver services. And so it creates a lot of complexity when each state agency has a different way of contracting, a different set of standards, a different set of data, a different timeline for contracts. And then when you put the intermediaries in the mix, then you have multiple contracts with multiple types of providers. And as all of you, many of you are providers, I know when you're at the bottom of this picture, it means quite a bit of complexity for you in managing the contracts and in managing the way in which contracting happens. So the model fixes this, if we go forward one slide, by creating these universal contract provisions. And I want to be clear about this because I know during the Behavioral Health Administration stakeholder engagement, there was some confusion about this. So I just want to say it as clearly as I can. This does not mean there's a single contract. It doesn't mean that everyone's signing one massive contract and that there's, suddenly only one contract that everyone's managing. All of these entities will still be doing their own contracting with providers. So state agencies will still be doing the contracts and the intermediaries will still be doing the contracts. What's different, or what we hope will be different, is that there will be a universal contract provisions. So there'll be a set of core contract elements that are consistent and standardized across contracts. And we know that that is not going to solve everything, but we are hopeful that it will help reduce some of the complexity from the previous slide. Also in that, we are looking at how to standardize and support improvement on contracting process so that the process itself gets streamlined a bit to reduce some of the complexity. The part of this that you can't see very well on the slide, over to the right in the universal contract provisions, there's this little program system, program specific addendum, these little dotted lines. That's really to demonstrate that although we're going to work on standardizing what we can within universal contract provisions, there still will be elements of contracts that are unique and specific. And I assume that makes sense to everyone, right? There are state agencies who have very specific programs that they need to contract for. They have a federal piece of data that they have to collect that's unique to that program. Array might decide it really wants to look at a certain part of quality or do something differently. We want to be able to build in, streamline as much as we can and build in opportunities for some of that special needs that are going to come through the contracting process. So if we go forward one more slide. Why are we doing this? I think we've covered a lot of this, but the reason that the state looked at universal contract provisions and baked it into the Behavioral Health Administration model was really to think about streamlining the process, reducing administrative burden, creating a core set of standards to improve quality, accountability, and measurement. It is also to help raise equality and accountability and to support a core set of standards across programs. Also streamline core data collection and sharing requirements instead of maybe defining, this is my favorite example, access to care can be defined many different ways with many different numerators and denominators. And so can we come up with a single definition and put that into contract, which would reduce providers needing to count the same idea and the same metric multiple ways. Creating a connection to the coordinated grievance process, which is an important part of the Behavioral Health Administration model. Standardized core financial reporting requirements, standardized requirements for integration with other health and human services programs, and standardized core access to standards with an emphasis on equity, diversity, and inclusion. All right, and I'm going to slow down a little bit. All right, so No, you're doing great. Actually, I think we can skip this slide. Great. So there are 2 slides here that show 16 provisions. And these are the provisions that are required in statute to be looked at within the universal contract provisions. So I won't necessarily read them to you, but I will try to kind of describe them a little bit and talk through them. So as part of the authorizing legislation and really thinking about some of the contract provisions that are going to be used, these are the 16 areas that will be the first step for universal contract provisions. It doesn't mean that in the future or even now, there couldn't be additional provisions that get standardized. So for example, if we look at many contracts and we see that the provisions are the same around another topic, it might be a good place to try to standardize them. But this is sort of a basic start with these 16 provisions. And a lot of these are actually already fairly standard within contracts. So minimum data collection and reporting, including electronic data and participation in health information organizations or networks. So really that getting at that data piece and data sharing. Grievance occurrence, reporting, including to the BHA. Collaboration with other state agencies. The use of evidence-based practices and some standard set of best practice or emerging practice or other pieces, especially as BHA and HCPF identify practices that they want to put in place or emerging community practices that are done through some of the co-design elements. Those could be things that were baked into the universal contract provisions. Access to care and quality of care standards, really around accountability and related back to making sure that contract provisions align with what's in statute and rule. Programmatic and financial reporting. Consequences for not meeting contract requirements, so getting at monitoring and enforcement elements of contracts. Standard payment methodologies based on provider type or other factors determined by the state. If we can go forward a slide. Claims submissions, billing procedures and guidelines, limitations of liability, which are fairly standardized across contracts now, but it'll be a space that there's probably a little bit of work to do. Compliance with behavioral health safety net standards, including provisions of services for priority populations, utilization management, and then thinking about utilization of required tools or programs that can improve quality outcomes, improve accessibility, improve assessment and management of health, social determinants of health supports, looking at affordability and referral and other state priorities. So how to think about standard elements that are aligned with where the state is trying to move in terms of its priorities. Similar to that is policies on accepting, discharging, triaging, and denying services to clients consistent with rule and other statute. There's a large emphasis as part of the behavioral health reform to really improve access to care and to improve standards around how people get into services. And so those would be elements that would be standardized in contracts. Standards for serving priority populations and high acuity clients, another core goal of many of the behavioral health reform efforts to really meet provider need and to meet individuals' needs. So making sure the services and the priority populations are being met and that the services are being paid for, and then compliance with applicable federal statutes, regulations, including anti-discrimination laws. So those are the 16 provisions that will really be the focus of these universal contract provisions. And I see the question in the chat about, are we going to have to follow a specific contract template or outline? We don't know the answer to that, but we are trying to think carefully about how to create contracting provisions that provide some flexibility. So for example, not all services or all providers deliver all range of services, right? There's a whole range of services delivered in Colorado. Not all providers deliver that full range. Not all providers the services would be eligible for necessarily all contract provisions. So trying to think about how you do how you have a template and universal contract provisions, but also how you have some flexibility in how you put the pieces of that contract together. So for example, thinking about modulars that can come in or not, and you would check the box saying this applies or this doesn't apply. Also thinking about elements that can be put potentially in a provider manual, so you have less in the contract and there's things you can amend outside of it. So I think, Dave, the question is that's part of the challenge of getting to universal contract provisions, and we will be continuing to talk about that, and that will be part of what we can talk more about with the draft provisions later this spring. So I would encourage you to continue to stay involved in the stakeholder process so that you can look at the draft provisions and react to those and give us some feedback on format. All right, I think there's one more slide. Yeah, so I just wanted to highlight again, and I put that information in the chat above, that there are some other opportunities to discuss universal contract provisions. Again, some of them are in person. There's also virtual sessions. All of the in-person have a virtual option, so you're welcome to attend those. We really do hope to engage with folks. I will also put my email in the chat. We are collecting questions and sharing those with the state agencies to get answers, because some of them have answers now and some of them need to be answered as we go through the process. And then also the BHA is working on publishing those frequently asked questions. So we have, I think, about hopefully 15 minutes. And so what we would love to do, I know all of you, I think you are all muted, but we would love to ask some questions and put them in the chat and have you respond and give us some feedback. So the first question that we have is really just, as you know, whether you're a provider or an intermediary or whatever stakeholder sector you come from, what are some of the contract provisions or processes that you are working in now, so that are part of your contracts now, that are duplicative or challenging that could be addressed in the UCP? So for example, people have talked a lot about the complexity of auditing. So tell us, what are some of the high priority areas for you to address in streamlining or standardizing universal contract provisions? And you can, again, just put some thoughts in chat. We might ask some follow-up.
I've also indicated in the chat that people can raise their virtual hand and we will call on them to provide that feedback live. Sometimes it's just a lot to type up.
Yeah, thanks, Marina. That's great. Much easier.
Yep.
So if you think about your contracts now, where are opportunities? Where do you have contracts where maybe they have slightly similar but slightly different standards that would be nice to standardize, or areas that you feel like there's duplication that could be the same, or any other priorities you want to share with us?
Elizabeth, go ahead.
Thanks. Hi, Gina. I think some of this information, at least on my end, I'll need to digest it a little bit more and come up with really good questions and responses for you. Do we need to email that to you, or is the document that Boyd put in the chat box, is that where we put the info or our feedback?
So I think there's a couple different ways I can answer that. It would be great if you want to email me. And the other thing I will put out there is, if you have contract provisions that are good examples, or sections of your contracts that you feel like are good examples that you want to share, it doesn't have to have names in it. You can take anything out that's proprietary or confidential, but the more you can give us very concrete examples, the better. And so absolutely, it's fine to think about this. You could join another session, Elizabeth, and share some thoughts after you've had time to collect your thoughts. You can send us questions in email, and you can also, feel free to send us any concrete examples, or even a contract. We are definitely looking at contracts, and the more detail we can get, the better.
Okay, thank you.
Other questions or comments, thoughts about what's a high priority? Okay. Are there things, if there aren't questions or thoughts about that, the other question that we have for you is, are there lessons learned or elements of your contracts right now that you think are really working well that you would want to see maintained? You don't want them to be changed. Do you think they're actually very helpful to contracting? So it could be something that you want to see a priority to fix, or something that you really are thinking is a good lesson learned. We could take feedback on either of those. And again, you can put it in the chat or unmute.
I have a question about that aspect. I'm Tamara from North Range Behavioral Health in Greeley. I wonder about the Qualified Services Organization, or the BAA. Would that be something that would be considered a part of this universal process then?
Sort of a standard BAA, is that what you're asking, Tamara?
Right, yes.
Yeah, I think that's that is not a question actually that anyone's asked yet, surprisingly. So I think that that is something that we need to take back and think about. My guess is that BAAs, because they are so specific to data, are likely not going to be standardized, but we could think about maybe certain provisions or best practices within BAAs as recommendations for how BAAs are done. I think it's a very good question. Can I ask you, do you have thoughts about that? Whether or not it would be better to standardize elements or not?
It seems like there's elements that could be standardized. Where sometimes the rub happens is because of the Part 2 rules being more careful. I think sometimes people that we contract with forget that North Range has to be more careful. And so we want to spell that out for them. And so I think that's where our rub winds up.
Okay. Boyd, I'm curious, have you seen that in the examples that we've been looking at? Has the BAA been included?
Well, they do have, through the controller's office at the state, so they have templates for all of the, the various types of contracts. They do have a template for the BAA. But as you said, there has not been any questions related to that, and it's really not within the purview of the 16, but obviously it does say this is, we're not limited to those 16. So if there's things around the BAA, we can definitely take a look at that.
Yeah. I appreciate you raising that, Tamara, and we will spend some time thinking about that. And I see some other comments from people thinking that it's a good point in terms of different kinds of parts of the data agreement.
Thank you.
Yep. Any other comments, questions? We have some more time, so it would be great to hear what people are thinking about this. We are also open to hearing general comments about the universal contract provisions, or any concerns that you have about the universal contract provisions. Yeah, Elizabeth, I think all of us would love to see the universal draft provisions, because it does make it more tangible and easy to look at. And we will absolutely hope to do that in draft form through this phase 2 of stakeholder engagement. We know that will make it easier for people to think about it. As you are thinking about the UCP and as you digest this, really, I would encourage you to think about where are times that you're spending administrative time on things that are, again, very similar, but slightly different contract to contract, because that's really where we can probably make the most movement, and looking at those 16 areas. Yeah, that's great, Pam. We appreciate that. It's fine to take time to digest and take the materials back. And again, we are open to, whenever you're ready to have those conversations, to give us some context or engage with us. We're happy to hop on the phone with you if that's easiest. Just let us know when you're ready to have those conversations. Boyd, were you going to say something? No, okay. All right, well, I think if there aren't any comments right now, which is fine, again, we know it was a lot of information, happy to have people spend some time thinking about it and reach out to us, and we can put Boyd's email in the chat for sure. I will turn it back over, and I think, Tom, I'm going to hand it to you.
Thanks for that, Gina. I appreciate you going over all that. First, let me introduce myself. My name is Tom Miller, he, him, his pronouns. I am the Division Director for the Quality and Standards Division within the Behavioral Health Administration. We can go to the next slide. Ryan Templeton and team was kind enough to put together this overview of the rule timeline and of the several slides that I'm going to go over. This is perhaps the most critical, at least in terms of where we are in the current process, timeline-wise, and what comes next. So I would direct your immediate attention to the top row, the darkest green box, because that speaks to where we currently are with submitting rules to the State Board of Human Services, what those rules contain, and what the timeline with specifics down near the bottom there, with when we go to the board for next readings, what steps we have to take at each part of the process, and then the final date there, you'll see that effective October 1st, 2023 date. And that's really the thing to keep your eye on, and I'll talk a little bit more about that October 1st date in a few slides. The next two lighter green boxes talk about the next sets of provider rules that the Behavioral Health Administration will be taking to the State Board of Human Services. So the next packet is going to be primarily about safety net and care coordination standards. And when we are planning on doing community-driven stakeholder engagement, and when that period ends, and when the first reading, which we're planning on in October, with second reading in November and effective date January 1st, 2024. And then finally, the third set of rules, provider rules, which will concern itself with involuntary mental health services, also known as 2765, residential child care facilities, controlled substance license or CSL, recovery support service organizations, and also known as RSSOs, and when we will take those to the board, and again, hopefully have an effective date of January 1st, 2024. The last thing I want to point out in this particular slide is the pink box, and that's administrative rules, and I'll talk a little bit about that later in terms of the differences between the two. Next slide, if you don't mind. So this is really what I'm driving at, and we're changing our language a little bit to get out of the weeds somewhat with reference to specific rules, or rather rule chapters, and talk more about provider rules, those that apply to licensed and or designated facilities with the BHA, and how those rules are enforced. Next slide. And then if we go back in time a little bit, this particular slide, what we're driving at is how we got to where we are now. The primary statutory sites here, House Bill 19-1237 and House Bill 22-1278, and how the two interact. So if we go back to 2019, that bill created the behavioral health entity license itself. It gave that authority to the Colorado Department of Public Health and Environment, and OBH at the time worked very closely with the health department in creation of those rules. And as a result of that, facilities that were previously individually licensed by the health department now fall under phase 1 of the behavioral health entity license. And all of those facilities were required to either apply for initial license or transfer their license type to the BHE starting July 1st, or by rather July 1st, 2022. Now, phase 2 was at the time going to be integration of the substance use disorder license that the Office of Behavioral Health and now the BHA has authority to implement. That was going to be transferred to CDPHE, and CDPHE was going to issue substance use disorder licenses under the behavioral health entity license itself. And that's where House Bill 22-1278 comes in, that bill took the behavioral health entity authority and transferred it to the BHA. And so the original timeline is that facilities that had a BHE license expiring after July 1st of 2023 would be renewing that license with the Behavioral Health Administration. And this is what I was referring to earlier in the slide. However, as a result of stakeholder input, we are working on a delay of the effective date of this particular rule. And at this point, we are talking about a statutory timeline change that will move that effective date from July 1st, 2023 back to October 1st of 2023. So all of these timelines will ratchet back accordingly. And that's what that asterisk in the last box there means, that by July 1st of the law as it's currently written, all those BHEs will need to be licensed by the BHA. And of course, we will move that back 3 months or whatever time frame is finally decided on in any statutory timeline change. Thanks. Next slide. So here's also a little background about how we arrived at what a behavioral health entity license is, and why hopefully it works to streamline what has been in the past multiple different licenses that facilities must obtain. Give full faith and credit and due praise to our friends at the Colorado Department of Public Health and Environment for inventing the concept of a cafeteria style of licensure. What that essentially means is that instead of multiple licenses that facilities might have had to get in the past, now a facility would apply for a single base license, the behavioral health entity license, and then plug in and out endorsements underneath that, depending on the types of services, which we are really referring to as endorsements, to that particular license. And if memory serves, the analogy that was used during the creation of that concept, and what I think amounted to almost 20 months of stakeholder and rule development, was we're talking about a pizza, and we are adding ingredients or subtracting ingredients on the top of that pizza, depending on whether people prefer pineapple or pepperoni. And in our case, what we're doing is expanding that concept and adding multiple more levels of service or endorsements. And the best example of that would be substance use disorder, which will no longer be its own standalone. I thought Mark might say he didn't like pineapple. I think I've heard him say that before. So instead of a standalone SUD license, we are talking about various levels of care according to ASAM that represent their own endorsement levels. So the reason that I get to that level of detail is that while there may seem to be lots of chapters and lots of rule, the main concept here is that there's a main license, the BHE, and a lot of those other chapters that you've probably looked at represent the various endorsements, which in some cases take entire license types that the Behavioral Health Administration currently has and makes them endorsements which can be more easily put into the base license or removed from the base license. Next slide. This slide is specific to what those types of endorsements are. So you see the base BHE license there at the bottom. And then you can think about these endorsements as either level of service, that would be on the boxes in the left, or population specific when we're talking about what particular group of people are receiving services. Next slide. So as a result of approximately 5 town halls and 20 more individual stakeholder engagement opportunities that the safety net team was involved in the drafting of the rules before we submitted that first group of chapters to the board. We identified these particular stakeholder concerns. They're not in any order of number 1 or number 6 level of concern, but generally speaking, these are the things that came out to us either through that stakeholder engagement, written or oral testimony in our first informational read to the board. So wanted to put that there so that you could see what other members of the community have identified thus far. Next slide. So here's additional detail about one of the main concerns that we've heard, and we have taken the opportunity with some of the backing up of our timeline to further engage on this one in particular. And this speaks to candidate level staff not making up more than 50% of an agency's treatment staff. This has been a long-standing rule when it comes to licensed SUD providers. But as a result of combining several different types of services under one BHE license, there's been concern that we are now applying this particular rule to those organizations that are providing mental health services under the BHE license. So we are re-engaging with stakeholders to talk about that particular burden. And also re-engaging in terms of how we change that to meet the dual requirements of high quality services without undue provider burden. More to come on that one. Next slide. And this is the next main area that we are also taking opportunity to re-engage with providers. And that is a lot of these rules are new, even if the concept is we're trying to streamline and create a single license type for a lot of these different providers. When does the BHA start to enforce? So we are also taking a step back and working with stakeholders and trade organizations to do what at least I'm calling a soft rollout on some of the enforcement provisions. That basically means that once these rules are effective, if we find that a facility is operating outside of the requirements in the rule, that what we do is take that opportunity to work together and help the organization come back into compliance rather than any overt type of enforcement action. The caveat here is always if there's imminent health, safety, welfare issues, we still will need to take more immediate action. Next slide. And then this is what I was referring to earlier in terms of trying to distinguish between provider rules that speak to the rules that apply to those facilities licensed and or designated by the BHA versus administrative rules that speak to programs that the BHA may implement through Joy and Mark's teams. Those specifics with the administrative rules are continuum of care, access to safety net services, whether those be delivered statewide or regionally or sub-regionally, how priority populations are identified and supported, regulations about the administration of BHA programs, as I mentioned, and then finally care coordination. Next slide. And finally, wanted to point out that while we do have the opportunity to re-engage with stakeholders, that window is still somewhat brief. That doesn't mean that we don't continue to take opportunity for feedback. What it means is that we take it and we integrate it into rules, as these rules are a living document, and it is our pledge that we continue to improve them as we go in order to improve behavioral health services in Colorado. I think I've overstayed my welcome, so on to the next speaker, and thank you for the opportunity.
Good afternoon, everyone. My name is Andrea Jones. I use she, her pronouns. I'm the Deputy Policy Director with the Behavioral Health Administration, and I am about to take you on a whirlwind quick tour of our BHA implementation bill, which is a bill that we are championing this session. I will try to be mindful of time here. I want to leave enough at the end for any of those lingering questions that anybody may have, but want to give you kind of a 30,000-foot overview of what this bill seeks to do and how that helps us. So the first, I've kind of lumped these into categories of what the amendments do, really. The first group of changes that we're proposing is really primarily to transfer and align the responsibilities of the BHA from where they were incorrectly entered as the Office of Behavioral Health, which is no longer an entity unto itself, just making sure that the correct entities are responsible for the correct pieces of programmatic and system development throughout. BHA was inadvertently also included on some specific programs that it shouldn't have been, and those should have remained department at large. So really, the majority of these sections that you see on your screen are about alignment, making sure the correct people are doing the correct tasks. Next slide. All right. Bill Section 4 clarifies that the BHA is the state agency responsible for BASO oversight, those administrative service organizations that we are in the process of creating. And also, again, this is more apportioning responsibility. And hang on, I want to make sure I'm on my correct notes page. There we go. All right. And it also establishes the BHA as a health oversight agency charged with appropriate oversight of the behavioral health system. This is associated with some federal data and privacy laws and data collection, that it's basically a federal designation, but it's just clarifying in this bill in particular that we are that entity for those purposes. And obviously our friends and sister agencies over at HCPF and another number of other state agencies we're aligning with closely to make sure service delivery looks like what we need and what we expect across the state. Next slide. Okay, these are the fun section updates regarding money, right? This makes sure that we are authorized to seek appropriate grant funding, gifts, and donations, anything from any source where it would be appropriate to help us in carrying out our mission. And it also continuously appropriates money to the 988 Crisis Hotline Cash Fund so that that will be an ongoing continual appropriation, and it's not something that we have to deal with on a year-by-year basis. Next slide. Okay, these sections clarify our seats on and our representation on a number of boards and task forces that are aligned with behavioral health goals throughout the state, keeping in mind that we're, you know, comprehensively supposed to be involved in these things. So, all right. Section 16 and 17, this is a work in progress. For full transparency, we are looking at aligning the behavioral health safety net provider definition and the essential behavioral health safety net definitions. We're doing a lot of stakeholdering around what these definitions need to look like, because it will dovetail into the approval process, all the licensing things that we have been speaking about up to this point. So right now, the language that appears in the draft bill right now that's public is probably not the final language that we're going to land on, but we're engaged in these conversations with any of our partners, and it's going to be neat. I'm excited about it. So, all right. Currently, the structure is for us, the BHA, to create one regional subcommittee of the advisory council for each of the established BASO regions. We're proposing to allow us to create a regional subcommittee structure, which we believe would allow for more than a one-to-one with the BASOs. So this way, the advisory councils, we can hear more voices, we can get more input depending on the needs of any specific region or population without being constrained to a one-to-one placement with those BASO regions. All right. Okay, and then this section is really clarifying that we need to align our care navigation programs with the care coordination infrastructure. This is another working hand in hand with a whole lot of people to make sure that we get this as close to right as we can, and making sure that we unhook it from being a crisis hotline specific program, so that we know sort of those systemic interactions between care navigation, care management, care coordination, and the infrastructures that already exist, along with the infrastructures that we're building. Okay. All right. And then these bill sections are primarily clarifying that individuals who are on a transportation hold have the same rights as the 2765 litany of rights, regardless of what location they are brought to or where they eventually end up. This is really about individual rights and making sure that they're protected between any number of ways in which you could enter into this system. And it also aligns the record release statutes for sharing of information to make sure that it's federally compliant as well, associated with those programs. See, I did that so fast because Tom, I'm blaming Tom for this one. So we are more than happy to reach out to you, talk to you about specific questions you may have about the implementation bill, concerns you may have, anything like that. I would ask that your primary point of contact should be Casey Badmington, who's our legislative affairs officer. Her information is up on the screen. She's an excellent first point of contact to get that meeting on the books, get something set up for us. And Ryan Templeton, who is the division director of policy and external affairs, is also a good point of contact, as well as myself. So I apologize for how quickly that went, but I'm so happy to answer any questions, as is Casey and Ryan, if you need to reach out to us with anything. And I will turn it back over to the group at large for remaining questions. 5 minutes left.
You know, it looks like Elizabeth had a question for Tom about how will the delay in rules being promulgated impact FY24 requirements for ASOs and crisis providers?
So if I understand the question correctly, it would be if some of these facility administrative rules are being pushed back, does that have a corresponding effect on pushback for the behavioral health administrative organization work. If I did interpret that question correctly, I'd say we do not anticipate a delay with BASOs, as we lovingly call that. Part of what we're hoping for in terms of any regulatory delay is that it not affect that work that takes place or is intended statutorily at this point to take place July 1st, 2024. Now, there was an asterisk there in the slide, and we are not set on what those timeframes would be because some of that is pursuant to approval of additional legislation. So please take that answer with a bit of a caveat that some of that may be subject to change depending on what we finally arrive at via legislation. I apologize. I guess I completely misunderstood that question, Elizabeth. Thanks for clarifying in chat. The rules that were to be effective July 2023, at this point, we are looking at that those rules will be effective October 1st, 2023. And those rules are the behavioral health entity rules and associated endorsements. I hope that clarifies.
Yes, thank you.
Thank you.
There was another question in the chat from Mary. I apologize if I'm mispronouncing that, but off the topic, but wondering when the BHA will have the standardized form for evaluations related to M1 holds.
Thank you for that. We have started some preliminary work and working with our attorneys general on revision of the M1 forms. Now, that particular statute, House Bill 22-1256 has passed, but as I mentioned that those particular rules, we are looking at introducing them later this year, probably fall, with hopefully a January 1st effective date. So some of that particular work is predicated upon those rules being introduced and made effective as well.
We can go ahead and go to the next slide. And Mark, I think this is yours.
You bet. Okay, well, thank you, everyone. As we wrap things up, just want to remind you again that we have these two opportunities for monthly engagement. So the provider convening that we're having now, third Thursdays, and then the fourth Thursdays are our town halls. You can go right to the BHA website. I put it in the chat, and there's a place to register for them. So feel free to do so. You also learn a little bit more about what each is for. And let's go to the last slide as we wrap things up. We will also be sending out a survey to everyone who participated that will solicit some ideas for topics. Again, this is a provider convening. Yes, it's an opportunity for us to share some information with you, but really it's an opportunity for us to connect. Here is, thank you, Joy, putting it in the chat for the survey. We've got some ideas populated. We'd love to kind of see if any of those resonate, but there's an opportunity right in that survey for you to give us topics that you want to hear about. Another thing we'd love to do is, again, an opportunity to kind of highlight the amazing work that so many of you are doing, where we see centers of excellence across the state. We want to give the opportunity to share that information with others. And the survey says we need permission. We will figure out how to make that work. And if it's not this link, we'll make sure that when we send the survey out via email to participants, that we get it right. So sorry about that. Well, thank you all, and we'll see you next time.